1, 2,
And
Patients here.
70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
Let's start with
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
yeah. Here, what are the echo people get?
And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of precision.
Right, like it's engineering or something.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, you know, there it is. It's totally binary, broken or not broken.
And honestly, that's comforting. We're just wired to like things that can be categorized and neatly visualized.
But then you step into the world of critical respiratory failure, and suddenly that x-ray machine feels woefully inadequate.
Oh, completely.
Because we're looking at this dynamic, shifting landscape of pressures and gases, and it is, honestly, terrifyingly fast. Human life hinges entirely on the continuous exchange of oxygen and carbon dioxide.
Yeah, you could have the most advanced million-dollar oxygen therapy running, but, I mean, without a patent airway, none of it matters. The patient dies. It is really that stark.
The margin for error is basically non-existent.
That's why in the ICU, we don't just, memorize protocols. We rely heavily on pattern recognition and an absolute command of the underlying physiology.
Right, because if you don't understand why the lungs are failing, your interventions will probably just kill the patient faster.
Exactly.
So today, we are cutting through the noise. We're taking an elite intensivist's approach to critical respiratory care, filtering out the fluff, and aggressively applying the 80-20 rule to our sources.
We want to give you, the listener, the exact tools to anticipate respiratory collapse before the monitors even alarm.
We're looking at what actually kills the patient first, how to manipulate chest pressures, and how to outsmart the ventilation equipment keeping them alive.
And it fundamentally starts with a mindset shift regarding oxygen itself.
Yeah, because we are socially conditioned to view oxygen as this universally good, healing substance, right?
Right. But clinically, oxygen is a drug. Yeah. It has a specific dose, it requires a prescription, and most importantly, it has severe toxic effects if misused.
Which is wild to think about, because if you deliver a fraction of inspired oxygen, the FiO2, greater than 60% for more than 24 hours, you trigger this dangerous physiological cascade.
Yeah, you are essentially creating a massive amount of oxygen-free radicals in the body.
And those free radicals are super destructive.
Highly destructive. They actively attack and damage the alveolar capillary membrane. The endothelial cells lining the lungs just get chewed up.
Which triggers a massive systemic inflammatory response, capillary leak syndrome, basically.
Exactly. So fluid pours from the damaged vessels into the alveoli, creating non-cardiogenic pulmonary edema.
Wow.
And then you end up with blood shunting right past these fluid-filled, useless alveoli without picking up any oxygen at all.
So ironically, bathing the lungs in high oxygen concentrations directly destroys the lung's ability to absorb oxygen.
It's the ultimate paradox. And plus there's the mechanical issue to consider.
Right, because room air is about 78% nitrogen, and nitrogen doesn't really cross the alveolar membrane into the blood. It just hangs out in the little air sacs.
Yeah, it acts like a physiological stent. The nitrogen literally props the alveoli open.
So if we blast a patient with 100% pure oxygen, we are washing out all that nitrogen.
Which means once that pure oxygen diffuses across the membrane and into the blood, there's nothing left behind in the sac to hold it open.
It just completely collapses on itself.
That's the exact mechanism behind absorption atelectasis. By trying to fix hypoxemia with too much oxygen, you paradoxically worsen it.
Because you're collapsing the very structures you need for gas exchange. It's such a delicate balance.
It really is.
So when oxygen alone isn't cutting it, but we aren't quite ready to intubate, we step up to non-invasive ventilation, manipulating pressures to keep those airways open. Let's look at CPAP versus BiPAP.
Sure. So continuous positive airway pressure, or CPAP, delivers one constant pressure. Think of an alveolus like a balloon that has a tiny microscopic leak.
Okay.
If you don't maintain a constant inward flow of pressure, the walls are going to cave in on themselves. CPAP restores the functional residual capacity of the lungs by preventing that collapse.
But then there's BiPAP, which uses two distinct pressures. You have an inspiratory pressure to help blow off carbon dioxide, and a lower expiratory pressure to stent the alveoli open for oxygenation.
Right, and it's the gold standard for COPD exacerbations and heart failure.
But looking at the clinical triage here, if BiPAP is so incredible at doing the work of breathing for a failing patient, I would think we'd slap it on anyone struggling to breathe.
Like a trauma patient in shock.
Yeah, or someone with an altered mental status.
And that is a very common and very fatal novice trap.
Yeah.
You have to evaluate the immediate threat.
Okay, walk me through that.
Well, BiPAP requires a tightly strapped, sealed mask over the patient's face. If a patient has an altered mental status, say they're lethargic or confused, they physically cannot reach up and remove that mask.
Which means if they vomit.
The machine doesn't know they vomited. It just keeps forcefully blowing positive pressure.
Oh, man.
Yeah, it will take those stomach contents and drive them directly deep into the lungs. You've just traded a manageable respiratory issue for a massive, often fatal aspiration pneumonitis.
So altered mental status is an absolute contraindication for BiPAP. Problem, threat, intervention. The threat of aspiration easily overrides the benefit of ventilation.
Exactly. Now, sometimes the pressure problem isn't inside the airways. It's outside the lungs, in the pleural space.
Right. The physics of normal breathing rely entirely on a vacuum. The pleural space, that microscopic gap between the lung itself and the chest wall, operates on subatmospheric negative pressure.
So when fluid, like blood from trauma or air from a ruptured lung, accumulates in that space, we lose the vacuum.
That negative pressure turns positive, pushing inward and literally crushing the lung.
And our intervention is to place a chest tube to evacuate that fluid or air and reestablish the negative pressure.
But placing the tube is only half the battle. Managing the drainage system, specifically interpreting the water seal chamber, requires intense vigilance from the nurse.
It really does. The classic normal finding you want to see in that water seal chamber is tidling.
That's where the water level rises and falls in perfect sync with the patient's breathing, right? It rises when they inhale and drops when they exhale.
Because the water is directly reflecting the pressure changes happening inside the patient's chest cavity.
So if that tidling suddenly stops,
the system is no longer communicating with the pleural space. The tube is either blocked by a clot, it's kinked, or the patient's lung has fully re-expanded.
And as the clinician at the bedside, I'm constantly watching for the deterioration triggers. I'm worried if I see active hemorrhage.
Which is defined as drainage exceeding 200 milliliters in the first hour, or consistently greater than 100 milliliters an hour after that.
Because that volume of blood loss means you are moving from a respiratory problem to a full-blown hemodynamic crisis.
Exactly. Another severe warning sign is rapidly spreading subcutaneous emphysema.
That's the crackling, bubble wrap sensation under the skin when air leaks into the soft tissues.
Right. And a little bit around the insertion site makes sense, but if you feel that crackling traveling up the patient's chest and into their neck,
that air can literally swell the tissues enough to compress and occlude the trachea, which is terrifying.
It is. Now let's talk bedside emergencies. The chest drainage unit gets knocked over and the tube completely disconnects from the patient. What is your immediate instinct?
Well, if the tube is just hanging open to room air, every time the patient breathes in, they are sucking room air directly into their chest cavity.
Collapsing their own lung.
Yeah, so if I walk into that room, my brain snaps to one priority: trap the air. I grab the distal end of the tube coming out of the patient and submerge it in a bottle of sterile water.
That creates an emergency water seal. Air can bubble out through the water, but it can't get sucked back in. It buys you time to prepare a new drainage system.
What I found fascinating in our research is the strict never do this list for chest tubes. For instance, you never milk or strip the tubing to clear a clot.
Oh, never. Squeezing and violently pulling down on that tubing generates wildly dangerous negative intrathoracic pressure.
It can literally suck lung tissue into the eyelets of the catheter and shred it.
Yeah, it causes immense tissue damage. But the absolute deadliest mistake seems to be clamping the tube.
Unless you're just momentarily checking for the source of an air leak, you never leave a chest tube clamped.
Let's trace the physiology of a clamped tube. If a patient still has an active air leak in their lung, air is escaping with every breath.
Right.
If you clamp the tube, that air has nowhere to escape. It rapidly builds up inside the chest cavity, creating a tension pneumothorax.
The pressure gets so high it pushes the entire mediastinum, the heart, the trachea, the major vessels over to the opposite side.
And as it shifts, it physically crushes the superior and inferior vena cava. Blood can no longer return to the right atrium.
So your preload drops to zero, your cardiac output stops, and the patient goes into obstructive shock and dies.
Exactly, too.
So if we're boiling this first section down to the 5 things you absolutely must remember.
Number 1, core pathophysiology. Positive pleural pressure collapses lungs. Chest tubes restore that vital negative pressure.
Number 2, key assessment. A lack of titling means a blocked tube, while brisk bubbling in the water seal means an active air leak.
Number 3, most dangerous complication. Attention pneumothorax from clamped tubing.
Number 4, priority action. Submerge disconnected tubing in sterile water immediately.
And number 5, treatment. BiPAP is fantastic for COPD or heart failure, but it is absolutely contraindicated in altered mental status.
So the one-sentence clinical picture. If you see a clamped chest tube and a dropping blood pressure, think tension pneumothorax and unclamp it immediately.
That's the intensivist mindset, understanding exactly how the physics govern the physiology.
Okay, so when non-invasive measures in chest tubes fail, we escalate. We have to secure the airway. Let's dig into mechanical ventilation.
Because strapping a patient to a machine that breathes for them introduces a massive physiological plot twist.
It changes the entire paradigm of how the human body moves air. Like we discussed, normal, spontaneous breathing is a negative pressure system.
Your diaphragm drops, creating a vacuum that pulls air in.
But a mechanical ventilator is a positive pressure system. We are forcefully driving air down into the lungs.
We're blowing them up like balloons inside a closed box. And that transition from negative to positive pressure has profound hemodynamic consequences.
The initiation of positive pressure ventilation and the addition of PEEP, positive end expiratory pressure, causes a sudden spike in intrathoracic pressure.
And we just established what happens when pressure rises in the chest. It squeezes the major vessels.
Precisely. That positive pressure compresses the vena cava, reducing venous return to the right side of the heart.
Less blood returning to the heart means less blood available to be pumped out of the heart. The cardiac output falls.
Which is why the classic predictable clinical finding immediately following intubation is a sudden, sometimes profound drop in blood pressure.
The patient's hemodynamics crash because you literally took away their negative pressure vacuum.
That makes perfect sense. If you see that sudden hypotension after intubation, you don't panic.
Right. You recognize it's decreased venous return from the positive pressure, and you anticipate needing fluid resuscitation or a temporary vasopressor to support them.
It's all connected. Now, before we even worry about the blood pressure, how do we know the tube we just placed is actually in the trachea and not the esophagus?
Well, listening to bilateral breath sounds and getting a chest x-ray are standard, of course.
But the absolute gold standard for confirming placement is end-tidal CO2 monitoring waveform capnography.
You want to see a sustained, steadily rising CO2 value with a consistent waveform on the monitor.
Because if you accidentally intubated the stomach, you might get a tiny blip of CO2 from swallowed air, but it will quickly flatline.
A sustained waveform proves you are actually ventilating the lungs.
Once the tube is verified, we have to dial in the ventilator settings. Looking at the different modes, assist control or AC mode really stands out.
It's a very common starting mode.
It reminds me of having an overly aggressive spotter at the gym. If I'm on the bench press and I try to lift the bar even a fraction of an inch, the spotter immediately yanks the entire weight up for me. I do zero work.
That's exactly how assist control functions. You set a baseline respiratory rate and a specific tidal volume.
And if the patient attempts to take a spontaneous breath above that set rate,
the ventilator senses the effort and forcefully delivers the full preset tidal volume every single time.
So let's apply our clinical reasoning here. Say a patient is on AC mode, they start waking up, they are anxious or in pain, and they start breathing 35 times a minute.
Because of the AC mode, they aren't taking 35 shallow breaths. The machine is blasting them with a massive full tidal volume 35 times a minute.
The failing physiology there is extreme hyperventilation. They're blowing off massive amounts of carbon dioxide.
Which means their blood is becoming severely alkalotic.
Yeah.
The immediate threat is profound respiratory alkalosis, which can trigger seizures and lethal arrhythmias.
So if they're blowing off that much CO2 on AC mode, you'd either have to heavily sedate them to knock out that spontaneous breathing drive, or switch the mode entirely, right?
Yes, exactly. You'd step them down to synchronized intermittent mandatory ventilation, or SIMV.
How does that one differ?
In SIMV, if the patient takes an extra breath, the ventilator just lets them take whatever volume they can pull on their own. It doesn't force a full volume breath on them. It shares the workload.
But regardless of the mode, forcing air into sick lungs comes with the risk of trauma, especially if the lungs are stiff and non-compliant, like in ARDS.
We're looking at two major throats there, barotrauma and volutrauma. Barotrauma is pressure damage.
So if the inflation pressure is too high, the alveoli can literally rupture.
Spilling air to the pleural space and causing a tension pneumothorax.
And then volutrauma is volume damage. Pushing too large a volume stretches the lung tissue beyond its elastic limit.
The physical shear stress tears the alveolar cells, triggering a massive inflammatory cascade that floods the lungs with fluid.
Yeah.
You're basically inducing pulmonary edema by overstretching the tissue.
Okay, let's hit our 5 must-remembers for mechanical ventilation.
Number 1, core patho. Positive pressure ventilation increases thoracic pressure and drops preload and cardiac output.
Number 2, key assessment. Expect hypotension immediately following intubation.
Number 3, most dangerous complication. Unrecognized esophageal intubation or a tension pneumo from barotrauma.
Number 4, priority action. Confirm tube placement with CO2 and waveform capnography.
And number 5, most important treatment. Rapid sequence induction, using concurrent sedatives and paralytics to secure that airway fast.
The clinical picture. If you see a sudden drop in blood pressure and MAP immediately after intubation, think decreased venous return from positive pressure and prepare for fluids or vasopressors.
Perfect. So we've successfully manipulated the chest pressures, secured the airway, and managed the hemodynamics.
But keeping a patient on a ventilator introduces a whole new set of lethal threats, specifically the machine itself and the artificial airway.
This is where bedside alarm management is crucial.
If the ventilator screams high pressure, my brain immediately goes to obstruction. The machine is trying to push air in, but it's hitting a wall.
Right. The patient could be biting down on the endotracheal tube. There might be a thick mucus plug blocking the airway. They could be having a severe bronchospasm.
Or, worst case scenario, they've developed a tension pneumothorax and the lungs physically cannot inflate.
So if high pressure means a blockage, a low pressure alarm means the exact opposite. We've lost the closed circuit. It's a leak or a disconnect.
The tubing popped off the machine, the little balloon cuff sealing the trachea deflated, or the patient completely pulled the tube out.
Exactly. Speaking of keeping the tube clear, a lot of novice nurses assume that because the patient can't cough effectively, they should just routinely suction the tube every couple of hours.
Which is a critical error, right?
A huge error. Routine suctioning causes unnecessary trauma and actually increases the risk of infection. You only ever suction based on clinical indicators.
So if you physically see secretions, the high pressure alarm is going off, or their oxygen saturation is dropping.
Because suctioning is incredibly taxing on the body. It is a brutal procedure. Before you ever introduce a suction catheter, you must hyperoxygenate the patient with 100% FiO2.
And you strictly limit your suction passes to 10 seconds or less.
And while you're suctioning, you need your eyes glued to the cardiac monitor to watch for the vagal response.
Because the carina, the point where the trachea branches, is heavily innervated by the vagus nerve.
Yes. If your suction catheter hits that tissue, it triggers massive parasympathetic overdrive. You will see a sudden, severe drop in heart rate and blood pressure.
If that bradycardia hits, you stop suctioning immediately and hyperoxygenate. It's not worth stopping their heart to clear a little mucus.
Never. Now, let's talk about the silent killer in the ICU. VAP, ventilator-associated pneumonia.
VAP develops after 48 hours of intubation, and the pathophysiology is just sinister.
It really is. Secretions pool in the subglottic space, right above the inflated cuff of the endotracheal tube.
Over time, those bacteria-rich secretions slowly microaspirate past the cuff and down into the sterile lungs.
To combat this, we use the VAP bundle, which is really just a strict set of preventative priorities.
First, keep the head of the bed elevated 30 to 45 degrees to use gravity against aspiration.
Next, aggressive oral care with chlorhexidine to drastically reduce the bacterial load in the mouth.
Then, daily spontaneous awakening trials shutting off the sedation, coupled with spontaneous breathing trials to evaluate if we can get the tube out.
Because the faster the tube comes out, the lower the risk of VAP. Interestingly, part of that bundle is also not changing the ventilator circuit tubing routinely.
Because every time you disconnect the tubing to change it, you break the closed system and invite room bacteria straight into the patient's lungs.
Leave it intact unless it is visibly soiled. But what if the patient decides to remove the tube themselves? The unplanned extubation.
It is the ultimate bedside emergency. The patient wakes up agitated, reaches up, and literally rips the tube out through their vocal cords.
If you walk into the room and hear the low-pressure alarm blaring, and the patient who is just intubated is suddenly speaking to you, The tube is out.
My priority action is not to panic. I stay with the patient, shout for help, grab the bag valve mask, attach it to 100% oxygen, and manually bag the patient.
You are securing oxygenation while the team preps for reintubation. You are buying time by replacing the machine's job with your own hands.
Okay, let's do our 5 things for bedside management.
Number 1, core patho. Secretions slipping past the ET cuff cause VAP.
Number 2, key assessment. High pressure equals block. Low pressures equals leak or disconnect.
Number 3, most dangerous complication. Vagal-induced bradycardia during suctioning.
Number 4, priority action. Hyperoxygenate with 100% FiO2 before any suctioning.
And number 5, most important treatment. Daily SATs and SBTs to get the tube out as fast as possible.
The clinical picture. If you see a low pressure alarm and hear the intubated patient speaking to you, think unplanned extubation and bag the patient immediately.
Now, getting the patient off the ventilator entirely is always the goal, but some patients simply lack the physical strength or neurological drive to make that jump quickly.
For them, we create a surgical bridge. The tracheostomy, usually placed 10 to 14 days into intubation.
It's a stoma surgically cut directly into the trachea, bypassing the mouth and throat entirely.
And bypassing the upper airway drastically reduces airway resistance, which decreases the work of breathing and makes weaning much more achievable, right?
Exactly. It also allows the patient to wake up, move around, and even speak or eat in some cases.
But the track tube introduces a hyper-specific set of risks, particularly regarding the cuff that seals the airway.
There's this incredibly strict Goldilocks zone for the cuff pressure. It must be maintained strictly between 20 and 30 centimeters of water pressure.
The underlying physiology here is entirely vascular. The capillary perfusion pressure of the tracheal wall is roughly 30 centimeters of water.
So if you inflate that plastic cuff to a pressure higher than 30, it physically crushes those tiny blood vessels.
You completely cut off the blood supply to the tracheal tissue.
Which causes ischemia, leading to necrosis, tissue death, and permanent tracheal scarring or fistulas.
But if you underinflate it, dropping the pressure below 20,
you lose the seal. Oral and gastric secretions will slide right past that loose cuff into the lungs, leading to massive aspiration pneumonia.
We use the minimal occluding volume technique to find the exact pressure that stops the leak, but nothing more, and we verify it with a manometer.
It's a razor's edge. Now let's talk about a nightmare scenario. A patient has a brand new tracheostomy, they cough violently, and the entire tube blows right out of their neck.
Accidental decannulation.
Your clinical reasoning here depends entirely on time. If that surgical tract is less than 7 days old, the tissue has not matured.
The moment that tube comes out, the muscles and tissue of the neck will instantly snap shut.
It's a lost airway. You can't just shove the tube back in because you'll likely just blindly push it into the soft tissue of the neck, creating a false tract.
And completely occluding what little airway they had left.
Exactly. So your immediate triage. Place a patient semi-Fowler's, grab a sterile dressing, and press it tightly over the hole in their neck to seal it.
Then you take your bag valve mask and you ventilate the patient normally over their nose and mouth.
You just go back to basics. Unless, of course, they had a total laryngectomy where the upper airway was surgically removed.
Because in that case, the mouth isn't connected to the lungs anymore, so you have to bag directly over the stoma in the neck.
That is a rare but critical distinction to make. Finally, how do we evaluate if this patient is actually ready to breathe on their own?
Weaning. We looked at hemodynamic stability, a decent oxygen ratio, and a specific metric called the Rapid Shallow Breathing Index, or RSBI.
We want the RSBI to be less than 105.
Let's break down why that number matters.
Yeah.
The RSBI is calculated by taking the patient's respiratory rate and dividing it by their tidal volume in liters.
So if a patient is breathing comfortably, say 15 breaths a minute, with a nice deep volume of half a liter, the math gives you an RSBI of 30. That's a strong, healthy pattern.
But if they are failing, they start panting like a dog. Their respiratory rate shoots up to 35, but their chest muscles are so exhausted that they are only pulling in tiny, shallow volumes, like 0.25 liters.
You divide that high rate by that tiny volume, and suddenly the RSBI skyrockets to 140.
A high RSBI proves the patient's respiratory muscles are failing. Anything over 105 means they are not ready.
So if we attempt a spontaneous breathing trial, an SBT, and the patient starts failing, they get tachycardic, tachymag, and their oxygen drops. We stop the trial.
But we don't just try again an hour later, right?
Absolutely not. When they fail, they have completely depleted the glycogen stores in their respiratory muscles.
You must put them back on full ventilator support and let those muscles rest completely for 12 to 24 hours.
If you push them too soon, they will just fail again but harder.
All right, our final 5 things.
Number 1. Core patho. Overinflated cuffs cause tracheal necrosis by cutting off capillary blood flow.
Number 2, key assessment. Cuff pressure must be strictly maintained at 20 to 30 centimeters of water.
Number 3. Most dangerous complication. Accidental decannulation in a tract less than 7 days old.
Number 4, priority action. Cover an immature stoma and bag over the nose and mouth during accidental loss.
And number 5, most important treatment. Rest respiratory muscles for 12 to 24 hours after a failed SBT.
The clinical picture. If you see a newly trached patient dislodge their tube and turn cyanotic, think lost airway, cover the hole, and bag the face.
That brings us full circle.
We started this deep dive looking at the hidden dangers of oxygen toxicity, mastered the physics of pleural pressures and chest tubes, unraveled the hemodynamic traps of positive pressure ventilation, and traced the exact pathways for preventing VAP and safely weaning a tracheostomy.
We've basically built a blueprint for thinking like an intensivist, understanding not just what is happening, but exactly why it's happening at a cellular and physical level.
It's intense, but that deeper understanding is what separates adequate care from truly life-saving intervention. And to leave you with one final, provocative thought that builds on everything we've discussed. Think about the famous hypoxic drive in COPD patients.
The classic medical fear. We're constantly warned not to give COPD patients high-flow oxygen because we might knock out their physiological drive to breathe.
Right. But the sources we reviewed explicitly tear that fear down in an emergency context. The danger of withholding oxygen from a hypoxic patient far, far outweighs the risk of respiratory depression.
It goes back to our core principle. Treat the immediate lethal threat first. The real clinical failure isn't that a COPD patient stops breathing because you gave them oxygen.
If they stop breathing, you have a bag valve mask, you have a ventilator, you can fix that, you can breathe for them.
But what you cannot fix is irreversible cellular death.
The real failure is letting them die of profound tissue hypoxia because you were too afraid of a textbook complication to turn the oxygen dial up.
Don't let the fear of what might happen prevent you from treating the lethal reality right in front of you.
Take that intensivist logic into your next shift, your next exam, or your next emergency. You've got this. Thanks for joining us on this deep dive.